and welcome to day two of the WEDI National Conference, a virtual learning experience. It's indeed a pleasure to kick off our second day. And what I want to do is to first introduce our speaker, but before doing so, I want to make sure that we cover a couple of things in terms of today's sessions. Starting at 12 today, Eastern Time to 1, we will have Michael Berger from Point of Care Partners. And then we will be following from 1 to 2. Ryan Howells with Karen Alliance and Levitt Partners. But what I wanted to make sure is today we want to hear from you. Your questions are very important. First of all, we'll let the speakers know that they're either giving some information that they would like to follow up on, or that we are all listening intently. So in any event, we're looking forward to your questions. We certainly for next week, we have on October 13th, we have 2 sessions. On both open APIs, COB data. We'll also, on the 15th of October, be talking about innovation, attachments, and accelerating the FHIR with 275. And then on the 16th, starting at 11 in the morning, we will have our National Attachments Workshop. So how do you get your questions to us today using the Zoom platform? Please use your chat feature. And then I want to, so just send the message. We have one central location where my colleague, Michael McNutt, is handling the chat box. And then we will make sure that we are certainly getting the question presented. Don't pay attention to the box that we just circled here. It's the chat box. It's the one to the right. Just a little bit of we want to make sure that everyone is paying attention today. So we just did a little quiz here. So use the chat box, not the screen share. And with that, it's indeed my pleasure to introduce Mr. Michael Berger, who is a practice lead of EHRs and EDI at an organization that does a lot of work for a lot of organizations that are part of our industry, Point of Care Partners. And with that, let me just kick it off to Michael, and he's going to be talking about improvements to eligibility and formulary, its impact on real-time benefit check, EPA, and specialty enrollment. Michael, please, it's all yours.
All right. So I need to share my screen. Okay, so hopefully I'm sharing the screen that's entitled Improvements in Eligibility and Formulary. Can you assure me that that's what you're seeing?
Yep, you're good to go.
Excellent. Okay, I like it when technology works. So thank you, everyone, and good afternoon. My name is Mike Berger, and I'm going to take us through a couple of slides that we've prepared relative to eligibility and formulary. So it makes sense, just to get started, to sort of orient everyone as to exactly what it is that we're talking about. And so when we're talking about eligibility and formulary data, this screen is what it looks like in the EHR. And so this is a typical EHR e-prescribing screen. Granted, it isn't the fanciest. In the yellow box, you see some information about the patient's copayment information and the fact that there are coverage restrictions relative to what is being ordered. And then in the body of this screen, there's a bunch of icons, little yellow circles and triangles with an asterisk and all kinds of other information. The column that's labeled FM is the formulary column, and so there's a star to indicate that this particular medication is the preferred drug. So when a physician or a prescriber is looking at formulary and eligibility information, this is what they're seeing in the EHR sometimes. On the next screen is another example in the same EHR. And so in this EHR, the patient's prescription insurance has been identified, but yet in the yellow box, there's no copayment information available. There's no coverage information available. And when you look in the body of the screen, you see that everything is filled with question marks and there are no icons to indicate what's going on with this patient's medication coverage for the drugs that have been selected. And so you can see that while the information is available, it's incomplete. And you can imagine if you were a clinician trying to make a clinical decision, this kind of information displayed here wouldn't be particularly helpful. So let's talk a little bit about, with that as the background, let's talk a little bit about what I want to cover today. And first is, why should we even be revisiting eligibility and formulary data? It's been around in EHRs for quite some time, but there are some reasons to take a look at it and with the potential for some enhancement. There's a couple of misconceptions which we will dispel. There have been some improvements noted regarding eligibility and formulary information. And really, even though there are only modest improvements, these have very broad benefits. And then we'll talk a little bit more about one of those consulting expressions, threading the needle to maximize the benefits of using this type of information. I am Mike Berger. You can tell that that is a pre-COVID picture in the presentation. This is my COVID beard, which I've been informed by my family I have to save until at least after Christmas, I guess for obvious reasons. Point of Care Partners is a healthcare IT consulting firm. I'm located in Wake Forest, North Carolina, and we are really a boutique firm with about a dozen consultants and a few hundred on-demand consultants as we need them for projects. And we're really focused on healthcare IT, but in a circle around prescribing. That's really the basis of our expertise, and it has led us to all different kinds of organizations who are loosely related to the e-prescribing world. So everyone from pharmacy benefit managers to pharmaceutical manufacturers to health plans and PBMs to EHRs and EHR vendors and to those companies that have built products who wish to interact with EHRs. So that's a little bit about us and who we are, what we do. So diving right in, why are we revisiting this? There are a couple of misconceptions. Formulary and benefit check, which has been part of the EHR almost since the inception of EHRs, is not the same as real-time benefit check. We have a description as to how that process works a little bit later, but the difference is that the real-time check is actually an online transaction where data is moving from the EHR to the payer and back with information. Formulary and benefit, as it has been traditionally designed, is a distributed database that actually isn't an online transaction. Another potential misconception is that the eligibility information in the EHR will always be inaccurate. And so there have been some traditional challenges with the data in it being perhaps incomplete, and in some cases incorrect. However, the state of the art today is that that information is a lot more accurate really than it ever has been, but it suffers from sort of a bad reputation. And then another misconception potentially is that EPA, electronic prior authorization, can work without eligibility and formulary data, and it actually can't. The basis of the transaction, or the EPA transaction, is to know when prior authorization is necessary. So if the baseline in the EHR doesn't tell the prescriber that prior auth is necessary, there's no reason to do an electronic prior authorization transaction because there isn't awareness that prior auth is necessary. So a little bit of background to sort of ground us. What are these eligibility and formulary and benefit files? Why were they created in the first place? So if you think about when you go to a retail pharmacy, when a prescription has been sent there by your physician, the first thing that you do is you give the pharmacist or the pharmacy tech your prescription insurance ID card. And so based upon that information, they know who insures you for your prescription benefits, and they know the formulary that covers you as well. So they're able to tell at the pharmacy exactly what the story is for you, whether this drug is covered or not, if it's on formulary or not, what your copayment is, how much of your deductible has been met. All that information is available, but it's all based upon you showing them your insurance identification. A challenge, though, on the prescribing side is that the patient's prescription insurance information isn't tracked in the EHR. And if you think about it, that's logical because there isn't a reason for the physician to keep track of your prescription insurance because they're not using it for billing. They're not needing to keep it for any reason. So they don't usually ask for or save that prescription insurance ID number. So in order to make e-prescribing work, there has to be a way in the EHR to determine which PBM covers that patient and under which of their formularies. And so there's a couple of major PBMs, and each of those PBMs have hundreds, if not thousands, of different formularies. So in order for the EHR to be able to display information for each of the formularies, they need to know which formulary there is and which of the different formularies that that PBM offers pertains to the patient. To address this issue, many, many years ago, a company called RX Hub created a master patient index, which took information from all of the major PBMs so that it could be determined based upon a transaction, which formulary covered the patient, and then which particular formulary covered the medications that would be prescribed for that patient. This was all packaged up as a distributed database so that even though the eligibility transaction told the EHR which of the formularies applied to the patient, the actual formulary files are in a distributed database that gets updated periodically through companies like SureScripts and is available on every EHR. So in the traditional formulary and benefit environment, it actually isn't an online transaction that is telling the prescriber whether a drug is on or off formulary. That all happens as a distributed database. Now, as you can imagine, that's outdated technology. And as a result, there have been new transactions that have come along since this inception years ago to enhance the process to make it work a little bit more smoothly. So you've got things like a real-time benefit check. And what that does is it actually creates a transaction that goes from EHR to PBM and returns information to say, for this patient, for this medication, here's the formulary status, here's the coverage, here are any restrictions that there might be. There's also been a move towards electronic prior authorization. And electronic prior authorization enables the prescriber to answer the questions that are posed by the PBM and the payer to make sure that it is the most effective solution, the most effective medication for that patient. And that is a transaction that is now being conducted electronically as opposed to just a bunch of phone calls and faxes. And then lastly, sort of the new one of this bunch is specialty enrollment. So a specialty product, which tends to be more expensive and have much more limitations on it, there is an enrollment process that needs to happen in order for a patient to be able to receive that medication. So it's kind of like a prior authorization, but requiring more information. And so now there is a move to computerize that process in a specialty enrollment and its electronic transaction as well. The key, though, is that each of these new transactions is built upon the eligibility formulary and benefit check. So in order, for example, an electronic prior authorization to make sense, the prescriber needs to know that prior authorization is required when they're writing the prescription. So that information about whether prior auth is required is actually part of the formulary and benefit check. Similarly, for specialty enrollment, in the eligibility and benefit check, it's telling the prescriber there is more information that's needed for this medication. The patient needs to enroll in a program. So without that baseline eligibility transaction and the formulary and benefit check, these newer transactions really don't have a way to run. Now, the traditional formulary and benefit information really has gotten some bad reviews. So we took a page out of the world of Google here. Some providers are saying that some insurances are accurate and complete, some aren't. There's no consistency. And then some physicians will say, well, when I go to prescribe a medication, I see a pop-up that tells me that it's on formulary, but then when the patient gets to the pharmacy, the pharmacist tells them that what I've ordered is not on formulary or perhaps isn't covered at all. And so these struggles with the accuracy and the trustworthiness of the data that is in these files is something that has sort of plagued adoption over time. And there have been some improvements that are trying to address these issues, but as using a baseball expression, you only have a couple of at bats before the prescribers are going to lose patience with trying it. And so those are things that we need to sort of try to overcome. One of the reasons why that formulary data isn't trusted in the EHR is that 3 out of 10 patients that a prescriber is going to write a prescription for can't be found. Eligibility information can't be found for those patients in the EHR. There's a bunch of reasons. Those patients may not be insured by a PBM that is part of the EDI network. So the patient's information might not be in the eligibility file, or they could be in a plan that's carved out of that eligibility file for whatever reason. The patient might be dually eligible. They may have coverage in 2 different files. So there's confusion as to whether it is. And so the bottom line here, if I'm a prescriber and I'm going to write a prescription in my EHR and I see partial information in the eligibility response, well, is that information partially there because there is no information? Or is there information that's just not displayed? So I don't know who to trust or what to trust. And if I can't do things universally and treat every prescription that I write depending upon the information that I see, then I tend not to trust any of the information. So even though 7 out of the 10 patients have pretty robust information, those 3 that don't sort of spoil it for the rest. Taking it a step further, though, even for the 7 that the information can be found, there is still maybe missing information. If you think back to that EHR example, the patient's plan was identified, but there was no indication of whether there was a restriction or there was a quantity limit or there was a prior authorization. It just said no information available. So based upon that, well, is the information not available because there are no restrictions? Or is it just not available because they never added it to the files? So this is one of those challenges that the formulary data sort of has to overcome. There have been some improvements, and so we shouldn't focus only on the negative. The Pew Research folks published a study in the journal from American, from AMIA, American Medical Informatics Association, which showed that standardizing addresses in these eligibility inquiries dramatically increases the match rate. So by using the zip plus 4, those additional 4 digits on the zip code bumped up match rates by 3%. Standardizing the format of last names added an additional 1%. So, which letters, how to use hyphens and how to use spaces and how to use capitalizations and apostrophes. Standards like that increase match rates. and also things like phone numbers. Adding additional information can help to improve the patient matching in that eligibility file. Because remember, the way it works is the first step in the process is the EHR generates that eligibility transaction. The eligibility transaction returns to the EHR to say, yeah, we know who this person is, and they're covered by this PBM in formulary number 123. And so that is the very baseline in the process. There's also been a bunch of new ONC regulations, which are now mandating that EHRs support sharing of things like phone numbers, emails, previous addresses, other information that's going to dramatically improve the match rate to identify the patient and ultimately the formulary that covers them. And so there is an organization which you probably have heard of called the NCPDP, the National Council for Prescription Drug Programs. And this is the standards organization that is responsible for the maintenance of the standards that are used in electronic prescribing and associated transactions. And there's been a work group, or rather a task group at NCPDP that's been focused on the formulary and benefit file for a long while. Version 5 is the latest version to be introduced by NCPDP. It's interesting to note that the industry is still using version 3, which has been around for at least 7 years. So while the use of the formulary and benefit file has been broad, virtually, well, not virtually, every EHR that has achieved certification supports this file, but the file hasn't had any enhancements for many years. In version 5, there's a bunch of new things that have been added. You can see the list, which we won't mention. Well, we won't read it specifically, but for sure, things like EPA support and pharmacy network and approximate drug costs are going to be real helpful at the point of care for prescribers. But I did want to focus on 3 things: an indication-based formulary, support for specialty drugs, and a file expiration date, which are really going to move the needle in terms of the effectiveness of this file. Indication-based formulary is a great example. So today, a formulary is general. So a medication is covered or not covered, or preferred or not preferred, regardless of the reason for which the medication is being prescribed. So an awful lot of medications these days have more than one indication. And so there hasn't been a good way, other than over the phone, for a payer to be able to say, well, if you're using this medication to treat diabetes, here's the coverage status. But if you're using that same medication for weight control, then it's a different indication, and so the coverage may vary. What has been added to version 5 of the formulary and benefit file are ways for there to be support for 2 different uses for the same drug. And that's going to dramatically increase the ability to be precise with the formulary information. So it'll be not only based upon the medication and the payer and the patient, but it'll also be based upon what the medication is being prescribed for. Another is a specialty product indicator. So there are some general ways to categorize what is a specialty product. They tend to be very expensive. They tend to have a limited pharmacy network, so only certain pharmacies are able to dispense them. And they all tend to have prior authorization requirements. There are always some additional information that needs to be answered, or questions that need to be answered before a specialty product is going to be dispensed. However, in the EHR, there isn't an indication to the prescriber that what they're ordering is a specialty drug. And so over time, prescribers get to know which ones they are, but it's really more of a back of your head thing than it is information that's in front of you. So one of the things that's being introduced here is the ability to distinguish in the formulary and benefit information to say this medication is considered a specialty drug for this insurer, for this patient in this formulary. And there's a couple of different advantages. One of the ways is for payers that are integrated, both doing their prescription benefits and their medical benefits, messaging could happen indicating that there's coverage under the medical benefit or the pharmacy benefit, depending upon which it is. And for those that are non-integrated, let's say that they're just a PBM and only handling pharmacy transactions or pharmacy prescriptions, then they could send messaging back saying, hey, this medication, this specialty med isn't covered by the pharmacy benefit, so you need to deal with the medical benefit. Also, once this product, rather, once this indicator is in the file, then that will be a surefire way to kick off the specialty enrollment process. So right now, when specialty enrollment is necessary, there isn't a surefire way to know that specialty enrollment is needed. This change in the file will make that possible. And another very, very, very important challenge is around timeliness of the file updates. So it's a kind of a complex flow chart at the bottom, but in essence, the payer publishes the formulary. They transfer it over to one of the intermediaries, the EDI networks, such as SureScripts, who compile all this information and create update files for each of the EHRs. The EHRs then take that information and manipulate it to make sure that it will work within all of their versions of the software, and then they distribute it out to the products, rather to the practices that are using each of their EHRs. There's latency built into each step in this process, and while it is a fairly standardized process, so the steps are all well defined and the formats are well defined, with each step in the process, time is added. So one of the challenges that is sometimes seen in the EHR is that the prescriber is writing a prescription, but they don't really know the vintage of the information, of the formulary information that they're seeing. Perhaps that information hasn't been updated in 6 months. So the prescriber may be making a decision based upon data that's 6 months old. So one of the things, and it's a pretty simple thing, but it's going to be very effective, is to add an expiration date to the file that is in the formulary and benefit information that's in the file, so that the prescriber will know, oh, I'm making a decision based upon data that was refreshed this week. So I have a reasonable assurance that this is current. Or by contrast, they'll look at it and say, wow, this hasn't been updated since February. This may or may not be right. And so that is going to have an impact on the decision making as to what problem or what prescription is going to be selected. And so that's going to be a very nice improvement, I think. Now, EHRs also have a role. Because it's been so many years since the formulary and benefit file has had enhancements, has had new fields added, and has had fields clarified and improved, the EHRs frankly haven't invested a lot of effort into improving the user interface so that it is friendlier and easier to use and more meaningful to use. And so this is a good example. This is a current EHR that is in use today. And as a layperson, you have a lot of trouble understanding what it all means and how it all works. And we're all used to an iPhone. It's really, really simple. You can look at it, you can understand what it means. It doesn't require training. It doesn't require in-depth knowledge to figure out how something works in that environment or on the web. And so using this EHR, you'd really have to spend some time to be trained and remember, okay, if there's a yellow circle in that first box, what does that mean? And if there's a gold star in the FM column, but then there's a number 2 in the column after that, does that have significance? So the EHRs do have a role here, in that they really do need to rethink the workflow and the user interface to make this more meaningful. A physician only has a finite amount of time to be treating a patient, and they're not going to be apt to spend a lot of time trying to figure out the prescription coverage if it isn't really easy to digest and easy for them to understand. And the EHRs are really the way that that's going to happen. Now, providers also have a role here. It's one of those things where, so I am a former EHR product manager. I spent some time at Allscripts and what is today Greenway. And so the way that we prioritized the improvements that we were going to build into our EHRs was based upon feedback from our customers. Now, there's also a competitive element to that. You need to keep up with the competition. You need to keep up with regulatory requirements. And you need to be innovative and bring new feature and function, but you also have to pay attention to how your customers are using the information that is in the EHR and the way that the EHR has been designed. So providers have a role here too, in that they need to be vocal about when improvements happen in the EHR to let the developers know that, yeah, this is a cool thing and it's useful to me. So for example, I prescribed a specialty drug and the patient is on therapy in 2 days. Well, if you can kick off the specialty enrollment process and answer all the prior authorization questions at the point where you're writing the prescription, then you're dramatically decreasing the amount of back and forth that's necessary in order for the patient to get the medication. So if it all is programmed and it's understandable and it is in front of you, you'll take these steps as the patient is being prescribed and you'll get passed through that process. The patient will get the medication dispensed and they'll get on therapy very quickly. Another example is that we saved the patient $250 by ordering an alternative therapy. So if the information in the EHR is current and it's easy to understand, and there is a clear formulary alternative that's going to be significantly less expensive, the prescriber ought to be thinking in those terms. Order the one that's least expensive. One of the major reasons why that prescriptions are abandoned at a pharmacy is because the patient shows up at the pharmacy and they have sticker shock. They say, I can't afford to pay $250 for this medication. So then the pharmacist may make a call and say, hey, can we switch it to something else? All the while, the patient is standing there at the pharmacy counter getting more and more aggravated. So you having that information upfront and accurate and reliable will go a long way towards satisfaction, not only from prescribers, but from patients as well. And then I've noticed that the EHR is finding formulary status for more of my patients. That's another one. In order to engender trust in the data, the information needs to be there consistently, and it needs to be robust. So improvements in the files and making sure that eligibility matching takes place and making sure that the formulary data is correct and current is going to make it a lot more reliable, which means that physicians will trust it. And that trust factor is very important in order to get this adopted and used in the mainstream. Of course, there's benefits. There's benefits to using this data, and there's also benefits then to improving it. You want to maximize the value of the formulary tools that are available by providing high quality data, making it consistently available for use, and taking advantage of functionality that has been in the EHR for years and is kind of, I don't know if I would say fallen by the wayside, but it certainly has been deprioritized from the perspective of how providers are using the data and relying on it. Speed to therapy is a big one. Um, when you look at the studies of the administrative delays that result from prior authorization and specialty enrollment and even identification of specialty products, it can sometimes take a patient weeks to get onto a therapy that the doctor has ordered. And so you wouldn't be prescribed the medication in the first place if you weren't sick. And so being sick and then having to wait while there's all this back and forth and switching of medications and negotiating over whether it's appropriate or not. And all the while, the patient is there just getting sicker and sicker. So, speed to therapy is a very important measure. And if it's possible for the prescriber to make an informed decision while the patient is there, they're going to counsel the patient as to this is what you're going to get, this is how much it's going to cost, and I'm filling out all the paperwork right here and now so that when you get to the pharmacy, you're going to be able to pick that up. You can go through the drive-through. You don't even have to go into the building. And getting that patient onto therapy means that they're going to get better quicker. And it's also going to have a tremendous amount of satisfaction from the patient's perspective so that they're not subjected to those delays from the provider perspective, because they're not going to have to be faced with that back and forth conversation, asking a bunch of questions and then a bunch more questions. And even the payers are going to benefit from a higher level of satisfaction because personally, when I am faced with a prior authorization question and I know that there's a delay, I'm not pointing the finger at my pharmacist or at my physician. I'm angry with my insurer because I'm saying, look, I'm sick. I need this drug because my doctor said so. And I'm being run back and forth with all this information. So a streamlined process there increases my satisfaction as well. And that's really less friction. The more information that's available up front, the more quickly and the more effectively decisions are going to be able to be made. And that's going to mean a smoother process all the way along. And that administrative burden, sort of the bellwether of, or maybe the bane of every practice's existence, I guess. In practices, for example, my family practice here in North Carolina, they have a staff of 3 people whose job it is to talk to pharmacies on the phone. That's all they do all day long. And that has to do with calling back for formulary switches, for missing information, or for enrollment and prior authorizations. So if you think about that, I mean, that's one practice, and it employs 3 people to do nothing but administrative stuff. Wouldn't it be nice to be able to devote those 3 people to some patient-facing caregiving role, as opposed to just pushing paperwork back and forth? And so if you multiply that across all practices, there's a lot that can be gained by making sure that the prescription that is leaving the EHR is fillable without a lot of back and forth. So there's really benefit for all of the stakeholders. So I will leave it at that. Clearly, this is a subject that I could talk about all day long. I've been dealing with e-prescribing for probably 25 years. My contact information is here on the screen, my email as well as my phone number. And if there are any questions, I'll be happy to field them at this point.
Thank you, Michael. We're looking at a couple of questions in the chat right now. I have one for you. Since the formulary needs to be available via real-time APIs to meet the CMS rule for patient access, why wouldn't a provider look to take advantage of this more real-time option too? Seems silly not to make the same APIs available to everyone, since they need to exist to meet the regulation.
So that is an outstanding point. The challenge, though, is that it is in the way that the information is displayed in the EHRs. So in order for that real-time transaction to take place, the prescriber actually needs to select the prescription, select the medication, write the prescription, and indicate to which pharmacy it's going to be sent. And at that point is when that real-time transaction can take place in order to identify the formulary status and any restrictions and so forth and so on. And so it isn't practical in today's environment to be able to go through that entire process only to learn that you need to change to something else and then go through that entire process again. So that's why that the formulary and benefit file as it stands today is providing some guidance information in the drug selection so that the prescriber has an idea of what's the story with that medication at a higher level, at a plan level, when they're making the selection. So then when they've decided, okay, this is the one I want, then they're going to get the specific information. Just the technology hasn't evolved at this point, and the speed and the bandwidth that's necessary to do those transactions, and the patience of the prescribers to maybe try one, get some information, say I need something else, then to have to try another one. They want to have some assurance that the one that they're picking is going to be the one they need as part of drug selection.
Excellent, thank you. We have kind of a follow-up. It says you can get the full formulary via API or select a bunch of drugs and get info. It's not tied to a script in any way. I guess it's a statement to follow up your response.
Right. Well, that isn't our experience in the way the formularies are designed. So I don't know.
No, thank you. Any other questions, please feel free to type them into the chat.
So for everyone, this is your opportunity to continue asking questions of Michael. So if you have any further questions, again, please put it in the chat. So we're still monitoring the chat function, and let's see, Michael, there is another question that just came in is, how can prescribers get the information on drugs covered under the medical benefit?
Well, so that is an industry-wide challenge because at the moment, the formulary and benefit information is limited just to pharmacy benefit. So one of the changes that I mentioned is that there will be an indicator in the formulary and benefit file as to whether a medication is covered by that payer under their medical or their pharmacy benefit. So one of the future improvements that the industry is working to figure out is how coverage information and the formulary information for medications that are covered under the medical benefit can be displayed in the same way. But at this moment, all that we've talked about here is it pertains to prescriptions that are covered under the pharmacy benefit. And so that does leave a hole because so many drugs, especially the expensive specialty drugs, tend to be covered by the medical benefit these days.
Yeah, excellent question. And there's always that struggle of what's covered under the pharmacy benefit versus the medical benefit. Well, thank you for clarifying that. And I want to again, as we are closing out this presentation, remind everyone to respond to the brief 2-question survey that's currently posted on the screen. And if you will, it gives us a lot of feedback. So if you will, again, do that before we conclude. Is there, Michael, we ready to invite our next presentation?
I'm not sure that it is scheduled for 1
teed
o'clock.
up. Yeah. Okay.
So what we'll like to do is invite everyone just to take a quick break, stretch your legs out, and at 1 o'clock we'll be back with a presentation, our second presentation of the day.
Well, thank you everyone for joining us, and thank you, Michael, for your the great content and the great presentation. Again, we look forward to discussing this issue further. Thanks again.
My pleasure. Nice to meet all of you.
And everyone, enjoy your short break.
Thank you, Michael.
We'll be reconvening at 1 p.m. Eastern Time. Thank you.
Good afternoon, everyone, and welcome to our second pre-conference session of the day, Digital Identity, Authentication, and Federation, rethinking how we identify and authenticate individuals across systems. It's my pleasure to introduce John Kelly of EdFX, who also serves as WEDI's Education Committee co-chair.
Thank you, Michael. Appreciate that. Well, for today's session, the title being a mouthful, I'm not going to repeat it, but digital identity is certainly something that's going to be top of mind for a lot of folks, certainly in the industry as we implement the APIs. But before we get started, just want to cover a little bit of housekeeping. The sessions for next week's schedule, we have a full house. Weedy decided that, in lieu of people traveling to Germany for Oktoberfest, we were going to have Weedy Fest with a month-long set of content. We have our official national conference kicking off on the 20th this month, but prior to that, starting this week and then going into next week, we have an awful lot of information that we hope you'll find interesting and increase the value of your registration. We have open APIs about trust presented by Axway next week. A good session on the COB data insights for health plans from CAQH. Healthcare innovation catalyst from eSolutions, talking about the integration with HHS and turning 2020's challenges into opportunities. And then sessions on attachments from Tib Cohen Edifex, looking at a unified approach toward how the industry is reacting and how a couple of vendors are working with clients to move forward on attachments without having mandates coming forth from HHS. And then we have kicking off on Friday the Real Conference with the attachments workshop, a day-long body of content talking about where we are with attachments as an industry, where we're going, and some of the success stories of the early adopters. So just want you to know that in this new virtual world, the way we're handling questions is in the chat box on the screen. Use the chat feature, put your questions in there, and based on available time at the end, we will try to get as many of those questions to the presenters as possible. So with that, I want to introduce today's session. As I started saying, digital identity is the big barrel of worms that was opened with the introduction of the API rule. Everybody thinks it's great to get all this information into the hands of the members and the patients, that that's going to solve the interoperability problem and challenge we've had for the last decade. But along with that come all these ideas of how do we make sure that we're still protecting patients' identity, protecting the sanctity of their private information. Ryan Howells is a principal at Levitt Partners. One of his many duties is to be the program manager for the Karen Alliance. And in the Karen Alliance, dealing with the implementation of Blue Button with the APIs as well. The challenge of identity management and digital identity management in a modern age became top of mind for a lot of those folks. And so Karen branched out to look at this whole problem that the industry is facing, and they're contributing a whole body of work. I think that the stuff that you're going to see from Ryan is probably going to take on some very long legs over the course of the next 2021, 22, and you're going to be seeing a lot more in terms of digital identity and how it's leapfrogging the whole idea of patient identity. So Ryan, with that, I'll turn it over to you.
Great. Thank you, John. Appreciate it. I'm going to go ahead and share my screen here. The group. There we go. Did I get that working all right, John? You see it?
We can see you. Yep. And if you can move into presentation mode, I think we'll be, yeah, there you go.
Oh, sorry. Great. Well, again, thanks for the opportunity.
No, I'm sorry. You moved out. Sorry.
There we go.
There you go. Perfect. We're good.
All right. Appreciate it. Thanks again for everybody for providing us the opportunity. Just a little bit of background on what we're doing. I think most folks know in this group especially, but the Karen Alliance was formed about 4.5 years ago to get consumers and their authorized caregivers to easily get, use, and share their health information when, where, and how they want to achieve their goals. We have about 70 organizations that are participating in Karen today. It's an HL7 Fire Accelerator program similar to Da Vinci and Argonaut and Gravity and others that are out there. And we've got, some of the large tech companies like Google and Apple and Microsoft involved in it, as well as some of the largest payers in the country, as well as third-party apps and consumers and caregivers and pharmaceutical organizations and third-party apps. Whole bunch of folks that are, again, exclusively kind of focused on this idea of business to consumer data exchange. So really, to sum it up, we're trying to alleviate the business policy and technical challenges associated with how we do business to consumer data exchange at scale. Is kind of really our key function and what we're trying to solve for. I would also say that what we're doing is also building out this modern internet-based architecture, API, OAuth specific based architecture that allows for individuals to start to share data in a much more modern way in terms of how the data is shared between different parties. We recognize and know for certain that the data is going to be shared in many different formats, anywhere from EDI to CCDA to HLSET, all the different formats that are out there today. That will continue for a long, long time. This is another format that allows for third-party apps to then access the data, both on the business to business side, as well as the business to consumer side. And so what that has done for us is it's allowed us essentially a greenfield to rethink some of the common issues that we've had in healthcare. And so today, as I'm talking, this is by no means a solution to the problems that have encumbered us for a long time in healthcare. This is much more of a rethinking conceptual idea of what could be done in order to make this work at scale. We need industry help, including all those around the virtual table here, to help us with this. But we do know that it actually works for other industries in other countries. And I'm going to talk about that here momentarily. So this slide, hopefully folks have seen this in some way, shape, or form, but really this is the CMS Final Rule and the different implementation guides that are out there to help meet the needs of the CMS Final Rule. For the patient access API itself, DaVinci is providing a couple of those implementation guides to meet the needs of that rule. We're providing one called the Karen Implementation Guide for Blue Button that allows for the claims and pharmacy information to be sent across to the patient-facing app, and working with HL7 and the FM work group to make that happen. And then we also have, and I was appreciated point of care partners in their presentation earlier, what is called essentially the FHIR API real-time pharmacy benefit check implementation guide that actually not only has been validated, but also has been published recently as an STU1 standard to make that work for individual patients to access their information through a third-party app. So similar to what was discussed earlier in the earlier presentation, that there's a B2B flow for EDI-related data exchange for real-time. We've also developed a FHIR API flow to make that happen for the consumer via the third-party app. So what does that all lead us to? It leads us to this robust set of third-party applications who are going to access this information. And one of the questions we get a lot is, who are these third-party applications? So we stood up a website called myhealthapplication.com, where these apps have attested to what we've declared our Karen Code of Conduct that describes a set of best practices for apps that are not covered by HIPAA on what they should do to protect the information. The website's growing by the day. We think there's probably close to about 40 or so, 40 to 50, certainly less than 60 apps that have connected to a third party, to an API in production. The vast majority, half of those are listed on our My Health Application site. Some of the other ones are more business to business related apps. The VA Lighthouse has supported a lot of the work that we've done as well. Also Carry Quality and others. We're super excited about that because as this group knows more than anybody, interoperability is not a single person, single entity. It is an amalgamation of and a confluence of folks that have come together to actually solve this at scale. It's going to take all of us to help to make that happen. But with all of these apps, what we're seeing and what we're hearing from our members is that they are creating what they're calling really this new digital front door. And this is kind of be the baseline of our discussion today, which is, and kind of hopefully the analogy holds up as I go through this, but There are 4 things that they see as being critical to establishing their digital front door. The first is digital identity, not only for the individual, but then also for the organization. How do you uniquely identify a person or an organization for B2B, an individual obviously for B2C, across systems? What does that actually look like? So there's this combination of the publication of the endpoints, this combination of app registration, and the digital credential that we'll talk about here later. The second thing is obviously the API gateway. How do we control the data that's moving in and out of our systems? Many of the payers that we're speaking to have told us that they believe that the API gateway that they're establishing is going to be the core key function of how they exchange data going forward, and try to revert most, if not all, of those interfaces over to that gateway itself. And we'll have to see kind of how that operates long term, but that becomes the door to actually making sure the data can flow in and out of the system. The other thing is obviously we need individuals who care about this information. These are folks, we're calling them your family, but these are people you're trusted. These are members of your health plan. These are patients of your individual provider organization and others, to help them. You know who they are. You can give access to this information in a meaningful way. And then there's what we call the community of problem solvers. These are all these B2B and B2C apps that are out there that want to connect to this data and do interesting things with it. One of the challenges we've had in healthcare to date is that the ability for third parties to access this data it's been difficult, and especially with the rise of digital tech. There are literally hundreds, if you incorporate B2B apps in there, of apps out there that solve for specific use cases in healthcare. This new infrastructure allows for that to happen. But for this to work at scale, we need all 4 of these to work in harmony. We need to get the key right. We need to make sure the door is open and closed when it needs to be. We need to make sure we know who our family is, so that we can give access to those individuals. And then we need to understand who the community of problem solvers are and how we can actually integrate them based on specific use cases. So we're going to talk about identity today, just one of those legs of kind of the 4-legged stool. And hopefully folks are familiar with the NIST standards by now. They were named in TEFCA as being the preferred approach for how we identify individuals at an identity assurance level 2 and authenticator assurance level 2. They came out in the summer of 2017, and in August, and you can see this on our website, we pointed to the ONC and said, you should do this. This is super important because it's the only way that we're going to really be able to truly identify unique individuals across systems is by using these standards at scale. And we were pleased to see that they pointed to them in the TEFCA in January of the following year. But this provides really the ability for individuals to use a same baseline set of standards across these systems to do this identification. And as I mentioned, we have suggested that IAL2 and AAL2 are the foundation for making that happen. TEFCA also mentions FAL2 too, which we're going to talk about Federation in a little bit more detail. We held a summit last year with a whole group of folks, not only from healthcare, but outside of healthcare, about what identity means. And when we talk about identity, how do we start to get a common lexicon in place for how this works and how this could operate? And we kind of broke it down into 5 major categories. 1 is identity. Are you who you say you are? 2 is authentication. Can you securely log into the system? 3 is trust and federation. Can I actually use the similar identity credential across multiple systems? Can I federate identity? 4 is consent. Is the individual consenting that this is what they would like to do, not only with their identity credential, but what they want to do with their information? And then 5 is, once you've kind of got through many of those previous steps, how do we make the process of matching easier? In other words, if in fact we use the identity proof credential as our source of truth, how does that actually affect, or at least resolve or somewhat minimize the matching issue that we have today? We're always going to have to match up against individual records in the systems, and the demographic information and other things will not be consistent across the board. But if in fact we were able to use the member's credential, identity proof credential that they bring to the table, and that becomes the source of truth, does that over time make the matching problem easier? And it was this group's opinion that it likely does. And so we then went on a process last year and this year to figure out what would that actually look like. And I'm going to tell you some of our learnings as we go through the presentation. So first, the NIST standard. Again, for those who have not been able to read the NIST standard yet, we would definitely recommend that. I think everybody in health IT should be reading that, just in terms of, especially if you're working in the identity and access management space. But Identity Assurance Level 2 is replaces the old LOA form of identity itself. There is some idea there. I think the real big breakthrough that NIST had here is that there is both remote or in-person types of identity that can actually be done. So in other words, supervised or unsupervised ways in which actually identity could work at scale. That's important because there are vendors out there now that are offering completely unsupervised remote ability to actually do identity proofing, which we'll talk about here in a second, which allows for the individual to just start on their device, perform an identity proofing event, and then be able to use that event to actually authenticate themselves into various systems. And that was kind of the big breakthrough in this latest, this NIST standard. One example of that, and there's many, but one that is top of mind is mobile driver's licenses. So in 14 states right now, either in pilot or in production, there is the ability for an individual to voluntarily get a mobile driver's license as part of the Real ID program as well. Iowa is one of those states. There's many others that are out there too. But what's transformative about mobile driver's licenses is that now the individual is fully in control of the specific identity information related to them that they want to share. So for example, if they go into a bar and they get carded and they want to understand whether you're over 21, rather than showing them your entire driver's license, you can just show them in a trusted way that you actually are over the age of 21, rather than showing, again, all the address information, everything else associated with you as an individual. So it's a lot more privacy-centric way in how to make that happen. And there's obviously readers on the other side to make that transaction actually occur. But this also plays a key role in the digital space as well, given that the government, state government, specifically DMVs, are trusted sources for your digital identity. In fact, it's probably the most trusted source right now that we have as a country on digital identity. This allows for us to move to the internet space in order to provide this information as part of an authentication process across these different entities. And we're working with the folks that actually wrote the mobile driver's license standard. We're working with the folks that are actually starting to federate this and work with the DMVs to make that happen. And we'll talk about that a little bit more too, about how you can also find ways to be able to access some of this information, because it is available to the public. On the authentication side, and again, this is different than identity. This is, can I securely log in? Authentication has often just meant username and password. And while that is a good start, it certainly isn't an endpoint. In fact, if you talk to the NIST folks that we've done, and you talk to folks in the cybersecurity area, they'd say, well, every username and password essentially, in some way, shape, or form, is probably on the dark web somewhere, and can be hacked if, in fact, they decide to go down that path. And so the internet companies and others, the banking industry, have known that for quite some time and have tried to find ways where they can enhance the level of assurance associated with logging into systems. That's why these authenticator assurance levels were created. We are recommended AL2 or higher to make that happen. But what's also interesting, in addition to this, is that there was a group that was established, similar to what's happened with Karen and Da Vinci and others, of about 500 organizations that got together to create an open standard called Fido. And what Fido does is it actually increases the authentication security associated with logging in to these systems by doing two-factor authentication on the device. So what that means is using the biometric in your finger or your face and the cryptographic key that's in your phone, those are the two factors that actually authenticate you into the system rather than a username and password. That's kind of the easiest way to think about this. And it's public private key infrastructure. I won't go into all the details there, but there's this ability now where, again, you don't have to federate the biometric stays on the device. You don't have to federate the private key either. There's an ability now to make this highly secure. So now you have to be physically there with your phone, and you have to physically actually put in your biometric as well as using the cryptographic key in your phone to actually authenticate in. That level of security is much, much higher than it is anywhere else. Microsoft, Android, and iOS have all said that they're going to support Fido going forward, which means in the course of the next 12 to 18 months, actually Android, everything 7 or higher supports it today. But over the next 12 to 18 months, you're going to see it on iOS and Microsoft devices everywhere for free, open standard, very similar interface to Touch ID. In fact, many of you may have already encountered Fido as part of some of the banking logins that you're actually doing today. So we have been a fan of them for a while. Fido actually has a national conference here in the fall that we're speaking at to be able to integrate more with their community and bringing the Fido authentication event actually into healthcare as well. So Federation. So Federation was mentioned in the NIST standards. It's also mentioned in TEFCA as well. But the bottom line is it's really hard. And even NIST would tell you that they have had a really difficult time in trying to understand how Federation actually would work in a trusted ecosystem. Now, there are places where Federation is working at scale, which we'll talk about. But it is incredibly difficult. And as we think about a federated ecosystem, one of the things we have going for us in healthcare is we do have this thing called the Common Agreement, which is this public-private sector partnership, which is a legal agreement that's all volunteer, obviously, but it's a public-private sector legal agreement that can be put in place so that potentially Federation could actually work at scale between both public and private sector partners. And so we use that as the backbone for rethinking how we would create a federated ecosystem that allows this to kind of work at scale. And that's what I wanted to talk through about where we're focused on in the Karen Alliance specifically on how to make this work. Before I do, I wanted to talk briefly about kind of what we're calling kind of vectors of trust. And I got some of this information from our European counterparts who are working on this on an initiative called EIDAS, which I'll talk about in just a second. But when you think about trust, and this is really what Federation is about, is do I trust that that specific identity-proofed event actually occurred in the way that it should, that allows for that to be used in our system to authenticate? There's different gradations of trust, right? You can either rely on yourself and say that, look, that I am going to claim that I specifically was the one who evaluated my specific technology. And that is really the lowest level of trust. And then that obviously goes through and says, well, there may be an unqualified person who says that, no, you can actually trust this individual. Or there could be a qualified person, really a third-party certifier, so to speak, that says, no, you can actually trust that individual. So if the claim is actually provided by a qualified entity as well, and also evaluated by a qualified organization, that's obviously the highest level of trust. And so one of the things we've tried to do is when we're developing this framework around trust and identity, how do we ensure that the identity is actually validated by and claimed by trusted individuals or organizations? What would that actually look like at scale? And that leads us to the work we're doing in the Karen Alliance and how we're creating a digital, what we're calling a trusted federated identity ecosystem. So just briefly, kind of how this works. In the identity space, folks know that there's identity providers or issuers, as well as relying parties, folks that create identities and folks that rely on those identity providers to be able to ensure that the individual can be able to authenticate in. And there's all kinds of identity providers and issuers out there. I've listed a few of them on the screen, but that's definitely not an exhaustive list. And they use all kinds of technologies to be able to make identity work. Everything from OIDC, an API-related infrastructures, to PKI. Direct Trust uses a PKI system. There's also, Safe Identity uses that as well. And now through an emerging standard called Decentralized Identity or Verifiable Credentials, which is a W3C standard, which is kind of the newest technology that's being used in a decentralized way to be able to identify individuals. But regardless of the technology that's being used, these identity providers are providing these specific identities to relying parties. The question is, how do you trust them in a federated ecosystem? Well, that's where these trust framework organizations come into play, what we are calling certifiers. These are companies that you know of, Direct Trust, for example. Another one that you may have heard about, Contera, which is an international organization that has a trust framework. Safe Identity has been in healthcare for quite some time. DIAC is probably a new acronym for you, but it is part of what's called the Pan-Canadian Trust Framework, where the entire country of Canada got together to develop a trust framework for their 15 provinces across all industries. And I'll talk about that here in a second. But each of these are certifiers of those specific identity providers. Now, that works really well right now. What is missing is if an identity provider goes to one of these trust framework organizations and another identity provider goes to another trust framework organization, how is there equivalency across the trust framework organizations? That's where we come in, is Karen is focusing on developing contractual language that really starts to link these trust framework organizations together to establish equivalency. And that's the document that we're creating, and the document that these organizations that I mentioned here are going to sign on to in order so that there does become some equivalency across the market and the ecosystem on how identities could be shared across the system. So, and you can imagine this specific digital federated trust agreement, sorry, talking too fast, could be used, for example, or could be part of the common agreement, that public-private sector partnership I mentioned before. So on a volunteer basis, if in fact you're either a relying party or an identity provider, you can actually go to one of these certified trust framework agreements who are part of the common agreement itself, or trust framework organizations who are part of the common agreement, and actually be able to ensure that they are doing it in an equivalent manner. So, sorry, there's a lot of content, but happy to, again, answer questions as we go through that. Please put them in the chat and we'll see if we can get to them as we go through. So has this been done before? Is it even successful? Well, certainly in healthcare, I think we've tried, but we may not have had the infrastructure to really support it or not. But the European Union created this group, as I mentioned earlier, called EIDAS, which was really, it was a regulation that was passed a number of years ago, about 5 years ago or so, to establish essentially a federated agreement for the entire European Union in terms of identity. And you can go out there and see this regulation that's out there and how that works. There is an EID system that's associated with that, that's on a volunteer basis. But what this means is someone could go to an identity provider, they can get a trusted identity, and then they could use it not only within their own country across various industries, but then also across multiple countries in the European Union to make this work. And it is working well. It's up and running now. I think all the European Union members are actually participating in it, if I remember correctly. And so there's some really interesting stuff that's happening. Now, clearly we've tried that battle for quite some time to create a national regulation, a national patient identifier. So we're probably a ways away from doing that. I bring this up just in the sense of this has been done in other places, and it is working in production today. The other federated trust agreement that is in place that we know of at scale, at least at the scale that we're thinking about doing this in healthcare, is in Canada, as I mentioned earlier, through this organization called DIAC. And it's called the Pan-Canadian Trust Framework. So this is an organization, again, that they got together in Canada who said, look, there are specific things that we need to certify to make sure that identities can be trusted across systems. whether it's defining the participant, whether it's defining the specific information and authorization use, the technology infrastructure that would be supported here, the operations infrastructure as well, and how it's conforming to it, all under the guise of privacy and individual consent. This right now, as far as where they are in their process, they have developed and published their first set of draft recommendations, and then their first publication of the framework itself. And they're about to go into pilots later this year and into early next year on making this work for across Canada. We have folks from DIAC and specifically from Health Infoway that is representing the Canadian healthcare system there, who are participating in our work, providing us input and feedback on the lessons learned that they have had during their process. And you can imagine a day when even potentially you could use a digital credential that was created in Canada to be able to come here to the United States or vice versa. I know that seems very futuristic, but certainly on the realm of possibility as we're thinking through how we could make this work at scale. So I think this is my last slide, and then I'm happy to open it up for questions. But what should you do walking away from this presentation? Well, here's some suggested items for your individual action plans at your organizations or for the people who you support. The first thing that we are hearing is happening at scale right now in the industry, and that we're recommending as well, is to separate your identity and access management services from your backend systems. What that means is, most people have logins that are bolted right onto their core EHR or their core claim systems, either through the portal or some other way to make that happen. What we're saying is you really need to find ways where you can separate that. So you can do the identity proofing event, again, either with the organization or with the individual, completely separate from your backend systems. So then you can use your API gateway to actually provide the appropriate information based on the identity that's being presented to you and authenticated at that specific event. So that's kind of really step number one. And there's a bunch of vendors that can be able to provide services to make that happen. Number two is strengthening your authentication protocols. Definitely getting rid of usernames and passwords is a good approach. Moving to more of a multi-factor authentication approach is best practice. We mentioned Fido before. It's a W3C standard. At this point, you should look into that. You can Google that as well, FidoAlliance.org. I think it also has links to the standard that's out there. But this is a ubiquitous standard that's going to be everywhere. Strengthening your authentication protocols becomes really, really straightforward on a go-forward basis. The third step is supporting an IL2 identity-proof digital credential. As I mentioned, there's multiple identity providers on the market that provide these IL2 credentials. We talked about mobile driver's license, so talking to your individual state about where you are in that process. There is also, just so you know, AMVA, which is the Association of Motor Vehicle Association. I don't know what it's called. It's the Motor Vehicle Association place that has a link to an API in all 50 states where you could link to it and say, does Ryan Howell's driver's license that I'm seeing here and that he entered into my system, is that valid? Is all this information valid? And they will come back with an API call that says, yes, it is valid, or no, it's not valid. So that becomes one of the verification steps you can use. We are also working with the GSA and others on passport verification and the Government Services Administration, as well as other things where they can be trusted sources for how you can validate an identity. So if you want to build this yourself, instead of going out and getting an independent third party to actually build it for you, you're welcome to do that too. And then finally, we need as an industry to discuss ways to support a federated approach. So what does a CISO need to support a trusted credential from another location? Is that even possible? I remember 4.5 years ago when we started Karen, we had a bunch of chief privacy officers in the room and they said, absolutely under no circumstances would this data ever leave our four walls. It's never going to happen. Then there was the regulation, and now we're all into implementation. And we've at least got them to a point where they said, well, actually, this could work. And let's work together to make sure that the data is private and secure and consent-based. Now the question becomes, what does a CISO need to actually support a trusted credential from another location? they may not update their demographic information in their individual system with that information, but they could potentially trust a credential from another location or another identity provider as a relying party. What would they need to make that happen? What would you, as a system, what would that look like in terms of using that as the new source of truth? And then if you're interested in participating in these federated identity pilots in next year, kind of later this year, next year, let us know. I mean, you don't have to be a member of Karen to do that. We just would love to talk to you about if you're thinking about identity and access management and you're thinking about federated identity. Our next step, just so you know, is that we're going to have a white paper that we're in the process of drafting right now with this draft federated trust agreement published at some point in Q4 of this year. And again, that will be published on our website, open for public comment. We very much hope we get a comment from the entire WEDI community on that. And we look forward to hearing back from you. So there's kind of the information we've got. And I know we've got, looks like maybe a few comments in the chat, but happy to take any questions.
Well, thank you, Ryan. That was really a great presentation. I think you covered a lot of things that, A, if people are anywhere at all familiar with, you wrapped it into a nice package, and B, I suspect there's a lot of people who are wrestling with identity issues and are looking for sources of good solutions. So there's a lot in here. We do have a couple of questions popping up. One that occurred to me while you were talking is, you mentioned the different kind of suppliers of these various levels of identity. I know you talked a little bit about public key, private key stuff. I didn't see the certificate authorities on any of your lists. You had a kind of a layer cake in there. Are the certificate authorities, the Semantic and those guys of the world, are they involved in this process as well, or are they just a given at the bottom?
Yeah, it's not a direct correlation, John, but you can think of the certificate authorities as these trust framework organizations. Certificate authorities, yep, it's definitely in the internet context in terms of SSL certificates and other things too, but then it's also in the direct trust context as well. They play a little bit of a different role here, but really the trust framework organizations are the ones who are certifying the identity providers themselves and providing the information to, ensuring that the identity providers are doing it in a trusted way. Okay, thanks. We also have a kind of an interesting question about MFA being mentioned as an authentication protocol. And Glenn is reporting that they've had some challenges to this from clinicians. So at what point does this framework become mature enough that we have confidence? Yeah, so I think the way, and I'm not as familiar as I could be, but the way the DEA has the way that the EHR systems have implemented the DEA guidance related to MFA as part of the PDMP process is a little convoluted, and it's hard and it's difficult and it's hard to manage and all of that. And that's largely to do with the fact that most of the time not using as much kind of the current technology, the current standards around that. Think about it, I guess, in terms of this. Back to the Fido example, MFA actually becomes as easy as just putting your fingerprint on your desktop or on your phone, unlocking the system and being able to log in. It's the very similar interface as Touch ID. In fact, it's the same user experience as Touch ID, but what you're doing is it actually becomes your username and password. So I would say as of today, yep, pretty hard. Tomorrow, it's going to get easier. For example, Allscripts is using ID.me and implementing some MFA stuff related to some of the Fido things that are going on here too. So it's going to get easier, I think, over time. It's just it's going to take some time to make that happen. And then I guess if you can imagine a world where you use that strong authentication credential, where you're kind of using that Fido credential across multiple different systems on the same device. And by doing that, you're going to pull along your identity proof credential that's linked to that authentication mechanism. So what you're doing is every time that you use a Fido event and use your finger to actually log into a system, you're going to bring that identity credential with you through OpenID Connect, and you're going to then be able to authenticate yourself into these systems, and making sure that you've been actually identity proof going forward. So the user experience in the future is going to be related to simply, device-specific authentication that allows you to log into these systems much easier than you can today.
So it sounds a little bit like you're saying the technology is actually catching up to the use case that MFA we needed at a point in time, but the solutions weren't necessarily as cool as they could be. And now that we're getting to that point, maybe it will start to feel a lot better for providers.
Right.
So I guess in general, what, and I think you and I have had this conversation in different ways. We used to have this concept of the universal patient identifier. And another challenge that is top of mind for lots of folks is patient matching. Could you talk a minute about where does that intersect? Does this solve that problem, or how do you see this intersecting with the broader concept of patient matching and universal patient IDs?
Yeah, so universal patient identifiers does not solve the problem of identity proofing individuals across systems. And what I mean by that is there may be some ability to solve a little bit of the patient matching problem, but we don't solve the core issue of, are you who you say you are? And the reason for that is that, and I'll quote Dr. Rucker here with just as pumping a hand. He says we already have a universal patient identifier. It's called a social security number. And so that causes everybody in healthcare to bristle a little bit. But I think his point is valid in the sense that even though it came from a trusted source, even though it's standard and unique to you, it doesn't necessarily mean that you have been identity proof. Remember, the concept of identity proofing has to do with, in the physical world, you going to a driver's license, a DMV, and giving your housing bill and your passport and your old driver's license and all these different authenticators, these pieces of evidence that allows for the DMV to then say, yep, and I physically can see you in person. This is the person that's on all of these documentations documents. As a result of that, you've been identity proof. I now give you a credential, which is a physical credential, and you can go use that in the physical world. This is doing the same thing, but it's doing it in a digital way. You're getting multiple authenticators. And if we ever get an MPI passed, an MPI is really one authenticator out of many that you could use to perform an identity proofing event. And remember that the NIST standards, as folks read them, they have multiple ways to authenticate these individuals. And so you have to find ways where you're using multiple authenticators to actually make sure that they actually log in, or that they've been identity proofed, I should say. So I say that because, John, as we've talked about before, no, NPI does not solve the problem of identifying people across systems universally. And the other thing you should know is NHS has a national patient ID, and what they will tell you, Simon Eccles, who runs the NHS, will tell you is that has not solved their problem, their patient matching or identification problem across systems. So they are implementing Fido, they're implementing digital credentials, they are doing things like we're talking about here to make this work at scale. So we're just kind of leapfrogging that conversation a little bit. Regardless of what happens on the NPI front, we're not relying on that. We're basically saying that this idea of creating a digital credential has worked in Europe, it has worked in banking, it has worked in other industries. That's what we're going to try to apply here in US healthcare. And then if we ever get a universal patient identifier, we could bring that along with the entire grouping of information that we're trying to validate against. I hope that makes sense, John.
Yeah, it does. I think what I'm hearing you say is you need to have something, 1, 2, 3, 4, 5 that says that number is tied to a particular belly button. And then you have to have some kind of a digital identity certification that says this person you're interacting with is that belly button. That it's the combination of the two that actually solves the challenge to the industry.
Yeah, the way I'd present it is we are trying to memorialize and agree on a process for how you identify the belly button, is how we're thinking about this. Even if we had a national patient identifier, we haven't agreed as a country what the process would be to receive that national patient identifier. So all we're saying is, what's the process for doing that? What I would recommend if folks are super interested in this, Bill Foster, who's a representative from Illinois, has gone through and developed some legislation around this topic that we and Karen, it's on our Twitter feed if you want to go see that, have definitely endorsed. It describes a process, not specifically a number, for how to solve this problem. We're very supportive of what he's trying to do. So look at the foster identity legislation if you're interested there.
Well, thank you very much, Ryan. We're bumping up on the clock here, so I really appreciate your participating. And for the folks in the audience, if you thought this was interesting, this has been immortalized. It's been recorded, and tell your family, tell your friends, tell anyone else that you know that is aware of the WEDI conference that they missed something very cool, and that they should go see the recording. So thank you very much. Appreciate your support, Ryan.
Thanks, John.
Take care.